Good afternoon, everyone. Looks like it's just now noon. And as I say every month, this is a group that tends to be very large and joins a little late. So we're going to give it a few more minutes and then we'll get started. Okay, let's get started. It's a little after 12 and I know everyone is very busy. So welcome everyone to the July Research Town Hall. We have a wonderful group of presenters today. Dr. Klein is running late unless he is just topped on. So he has asked that we go on and get started and he will jump in when he can. So our first presenter today was to be Lori Young, and she was going to be talking about taking industry partnership to the next level. And unfortunately, she just got pulled into something else. And so I'm going to ask Amy Moseley, who has graciously offered to support and to present for Lori. So I'm going to hand it over to you, Amy.
Okay, thanks, Lee. I'm going to just say a few statements about the industry partnership team. We're a relatively young group here in the EVPRI office, and you can take that any way you'd like. I'll take it in the positive young way. The industry partnership team, I just wanted to give a few words about how it works. So the example that we're going to give today with HealthTrack RX is an example where a industry partner has approached UofL with some ideas about how to work together in a collaboration. And so Lori and I will talk to that partner and then find out more about their business, find out about potential collaboration opportunities, and then we go talk to researchers to understand what the researchers' interests are, how it could link up to a potential industry partner. And this process usually takes several months to figure out back and forth how this match could be made or not. And so I know a number of you have already talked to me about different potential research collaborations, and you understand that it does take some time because there's relationship building, there's understanding about what's in it for each party, because our industry partners are developing products and getting their name out there, and it's a business. And so once we see a match, then what happens next is that there's the contract potentially is made, managing the non-disclosure agreements. And those are things that our office will do, in addition to setting up invoices and leading discussions. And so there's a lot of opportunity out there for partnering with industry. And we wanted to showcase today an example of a successful research collaboration with a local industry partner. You can always reach out to our office if you have any ideas about companies that you want us to approach or that you are already working with if you need our help. So please contact us anytime. We have two speakers today for a collaboration with a company locally that's called HealthTrack RX. And Steve Goldberg, who's the Chief Medical Officer, is going to give the first presentation. And then that's going to be followed up by one of our local physicians, Christian Furman, who is working on this project along with others. And she'll talk a bit more about what the collaboration is specifically. And I can share the slides for both Steve and Christian. And I'm going to hand it over to Steve, who is with HealthTrack RX. It is the Chief Medical Officer there.
Amy, thank you. Good afternoon, everybody. Excited to participate in this conversation. A couple initial thank yous and recognition. HealthTrack got a view of the talent and capability of UofL, UofL faculty, UofL resources through a couple different pathways. First, I want to acknowledge Dean Bumpkus. Dean Bumpus took time, along with Dr. Emily Volk, to visit our campus in November of 2024, despite their very busy schedules. We were grateful for that. At that time, both of them were quite energized about UofL capability, talked about some research collaboration, and sure enough, that initial conversation created this collaboration opportunity. I also want to thank Dr. John Klein. Prior to my taking the role at UofL, I was an entrepreneur in residence. Prior to taking the role at HealthTrack, I was an entrepreneur in residence at the Center for Research and Innovation under Dr. Klein, saw the rich talent and capabilities of that center, which also gave me a very broad view of UofL capabilities. So those two different perspectives, when it actually came to HealthTrack, settled in, got a view of our business needs, identified them, and then we were able to engage with Christian Furman and Amy and present a collaboration opportunity. And sure enough, we've got a forward-looking study, which is about a $500,000 investment by our company. So I just wanted to share that cycle of conversation. that led to this opportunity. Now I'll move, if I may, a little bit about us and set up how it was a great fit to unlock diagnostic innovation, a strategic partnership between UofL Health and HealthTrack RX, and hopefully this can serve as a model for others. Next slide, please. We are an infectious disease testing enterprise. We focus exclusively on the outpatient setting. What we do is when patients present with infectious disease complaints, we offer the availability of a diagnostic insight to clinicians to help get the diagnosis right and the treatment right. Many clinical settings, the clinicians use only empiric decision making. In other settings, they have point of care testing, but sometimes empiric or point of care testing doesn't give confidence as to a right diagnosis and a right treatment plan. That's where we can come in. And with our strategic relationship with UPS, we offer the ability to turn around a test result within next morning timeframe by having samples anywhere in the United States picked up at 4, flown to SDF, taken to our lab, and then resulted out the next morning. We've served well over 8 million patients, participate with 5,000 practices, and we have over 12,000 referring regular clinicians. Next slide. This is the timeline of our company, founded back in 2010, had an accelerated pivot. Our chief scientist had the insight to develop our capability of PCR testing 6 months before COVID exploded. And then we were the 4th company to have an EUA, emergency use authorization, to offer the testing. So that was a jet fuel for our company. But then we ideated what might come next. And that's where we ideated fixed panel testing for different syndromes, with panels being formed by infectious disease experts. In 2025, we committed to, and frankly, just July 14th, opened a brand new lab, 40,000 new square feet at LabPort, not far from the lab. So that cuts a half an hour from tests coming in to coming to our lab. I'd welcome any of you to come by. It's a beautiful, magnificent, automated facility. I'd love you to see it. Next slide. In general, we are solving a problem that we're all aware of. Houston, we have a problem, and that is inappropriate prescribing of antibiotics. And there are a range of reasons for it, but at its highest level, it is causing antibiotic resistant infections, morbidity, mortality, so much so that worldwide it will be the leading cause of death in 2050. It's a major morbidity, death, and cost expense. And so with our diagnostic testing, you can get high sensitivity, high specificity as to the presence or not of an infectious disease pathogen, and then be able to gauge the patient in a shared decision-making conversation. And our data suggests that by providing that, you satisfy the patient in the urgent care setting, which is hard to do. They want to get better fast, and reduce downstream use of services and downstream use of cost because you're getting the diagnosis right and the treatment right earlier. Next slide. We serve multiple specialties. Frankly, half of our client business is in urgent care. It's high volume throughput, 15% infectious disease complaints. Next, pediatrics, primary care, women's health. PCR testing is really the standard of care for GYN and STI complaints. We're growing in other segments and other providers as well. Next slide. We offer testing that generates a report, which is on your right. On the left, those are the different anatomic areas that we test for. We use an open array platform, and guided by our clinical advisory team of infectious disease experts, to past presidents of IDSA, we continually refine the panels so that we look for a standard list of pathogens that's likely for that anatomic area or syndrome, and also are ones where that insight will impact clinician behavior. And those are the different body areas we check. Respiratory is obviously our leading testing area. To the right is our report, little hard to see. Key features I would point out are 4. We identify the pathogen. The second is we have a measure that uses PCR technology and correlates it to units of measurement common to clinicians. So PCR replication to colony counts. Next, we look at the DNA, RNA of the pathogens, and oftentimes they carry genetic resistance markers. We report those out. And then finally, there's not shown a suggested list of antibiotics if it's a bacterial infection, if it's felt to be a pathogen, and we start with a narrow and then move to broader spectrum. Next slide. A bit more detail on our report, which I just shared. And I would draw your attention to item 2 here, where we list the pathogens with suggestion of will be effective, A+, will not be effective, negative, based on the presence of the resistance genes. Resistance genes are genomic resistance, not phenotypic resistance. It is predictive. It's not 100%, but in a rapid turnaround environment of urgent care, clinicians like that insight, especially in the setting of climbing resistance. When I started primary care, trimethoprim sulfa was a go-to for UTI. Now resistance rates can be 30 to 40%. So you need these additional insights to support your clinicians. Next slide. For those who are not in molecular testing activity, and it took me a while as a primary care doc to get more comfortable with what it is. This is just a high-level illustration of how we do what we do. We have a single collection for each one of those syndromes. Once it's collected, and you need just a swab amount, because you will ultimately be replicating the nucleic acid. The sample's preserved, the organism is deactivated, then the DNA at the point of care, if it's a machine there or in our lab, is replicated. And the replications also are labeled with a visual signal. So there's a correlation between the volume of the pathogen that one could compare to a reference standard. And that's how we make a statement about either presence or not present. Next slide. We wouldn't need to do what we do if point of care testing, empiric decision-making, clinical practice guidelines were enough to support antibiotic stewardship. But despite decades of antibiotic stewardship education, inappropriate antibiotic for outpatient infections is still at 30%. I check with the CDC every 2 months to see if that number changes. It's still at that number. For respiratory, it's 50%. So something else is needed. The gap remains. It's our view that judicious use of our testing can help be a component of a continuum of stewardship activity. Next slide. We're growing quite a bit in the marketplace, but we also see it as a stewardship role. And frankly, payers demand it. to accumulate evidence about the clinical impact when our testing is utilized. Most of our research, not the U of L research, but most of our research on a scale of 1 to 7, with 4 being propensity matched cohort studies, 7 being consensus statements. We do a lot of level 4 data, also claims-based data, and also survey data. And this was one report that reflected our survey of 700 clinicians who used our testing. And they reported at high numbers that having access to our testing next morning changed their clinical practice to either short duration prescribing, waiting for the result, or no prescribing and waiting for the result. Now, we are doing additional study to validate that subjective report of the clinicians by looking at EMR data. And we already have some preliminary data, which we'll be socializing within the next quarter or two. Next slide. This is also looking at the downstream use of services and the downstream cost of services when our testing is used for respiratory infection. This was a claims-based analysis and propensity matched groups. And you'll have this as your reference. But what you will see is that there was an associated lower cost with the use of PCR versus culture, which takes a long time to result return, or empiric decision making. Next slide. This reflects what I verbalized previously about our initial provider survey data, that 80% socialized that they write fewer antibiotics or feel that they have improved accuracy of the antibiotic selection by waiting for the test result. We have a second survey that's accumulated that is consistent with these findings, and we'll be publishing those in the Journal of Urgent Care Medicine, likely before the end of the year. Next slide. Patients, when they come to the urgent care or primary care, are managing a lot. They've left work, they've got kids, they've got a team. And when I was early in practice, I was able to say, and it was sufficient, I think it's a virus, let's do conservative management. The expectations have changed, and people have an expectation for a definitive explanation and a definitive treatment with some evidence. And frankly, PCR, based on these two references, in general, is well received by patients when they have acute respiratory illness. And they have confidence in their diagnosis, and they're less likely to request inappropriate antibiotic treatment and report they're more likely to resume normal activities. Next slide. I'll wrap up here in the next 2 minutes. We have broad clinical relationships with our enterprise. We're growing at 30% per year, and so this reflects a large number of our clinical partners. But I will say that across those 8 syndromes, the area where we have, relative to payer point of view, insufficient clinical evidence of impact is the role of PCR testing versus empiric decision or culture for patients who have urinary tract complaints. And when we spoke with Dean Bumpus, and we spoke with Dr. Klein, and we spoke with Christian Furman, and then worked with Amy Moseley, we identified UofL as a wonderful partner to work with them to help them answer that question for us at the highest level of evidence possible. Next slide. We have broad health plan coverage. So for those who are asking, 80 to 82% of patients who get our testing anywhere in the United States have no out-of-pocket. In Kentucky, it's about 90%. And then it dials up to, frankly, a maximum out-of-pocket for our testing that we will assess a patient for of about $150. They might have a higher copay obligation from their health plan. We'll go through that adjudication as we're required to do. But that number I told you is what we target for maximum personal responsibility for any number of syndrome testings for one person in one day. Next slide. So in summary, we're growing. We are thrilled to be in Louisville. We are here because of the strategic opportunity that UPS presents. With this Traeger collaboration, we're excited to have a research partner to take on some very difficult questions that require answers generated from an elite clinical enterprise in an elite medical university in order to engage payers. We'll see what the results show. This reflects some accumulated work we've done on answering other questions. I think the next one, Amy, Q&A. Our peer-reviewed evidence, pardon me. Some of the papers I've referenced, a broader list. These are all peer-reviewed. Any questions, comments before I return it back to Amy? Okay, well, again, I want to thank Dean Bumpus and Dr. John Klein for creating the initial entrees into UofL. We're excited about collaboration, and Amy, we're enjoying the partnership greatly and look forward to the start of patient enrollment and the findings.
Thanks, Steve. That's a great presentation. We're going to transition to Christian Furman, who's one of the doctors on the collaboration for UTIs with HealthTrack RX. Christian is at the UofL School of Medicine. She's the chief division of palliative medicine and the medical director of the Traeger Institute Optimal Aging Clinic. And I'm going to share my screen. Give me a second here to share slides.
Thank you, Amy. Can you all hear me okay?
Yeah.
Perfect. So I'll thank you for this collaboration. And it was very interesting to talk, Dr. Goldberg. Thank you. We're having this clinical trial with UofL and HealthTrack RX to demonstrate clinical validity of using the PCR to diagnose urinary tract infections for faster symptom resolution than standard urine culture. And so we can go to the next slide, but this is really a partnership with the infectious disease, a division of infectious disease, and with that, with our nursing home. So HealthTrack RX, Dr. Goldberg spoke, and he's the chief medical officer there, but we're also working with Maren Fergala and Ozzie Evans and Jay Reddy. But at UofL, Laura Morton is the medical director. She's the chief of our division of geriatric medicine, and she's a medical director for our long-term care program, so medical director at nursing homes. So at Trayton Oak Towers, we're doing this research because the nursing homes is a huge issue with urinary tract infections where people are just continuously on antibiotics for no apparent reason, and they have all kinds of side effects. But Dr. Arnold is really leading this as the chief of the division of infectious disease. And his group, Stephen Goatee and Christina Cabanas-Winner and Jashura Ali and Dan Kapp and Dr. Shaluki and me. So all of us are kind of working together on this, and it's using this academic and industry partnerships will accelerate the solutions to help patients get better faster is what we're hoping. So it's a collaboration with UofL Health, with University of Louisville School of Medicine. So go ahead, we'll go to the next slide. And so our problem to address and the hypothesis, the problem is these urinary tract infections. That's the most common one that we see. And by age 32, 50% of women will report at least one UTI in a lifetime and 25% recurrence rate. And the current, how we do make a diagnosis of a urinary tract infection is a urinalysis and a culture. The culture, you have to have greater than 100,000 organisms. But the culture takes 3 to 5 days. In the meantime, the patient can get very sick and, it's a lot of delay and be on antibiotics they don't need to be on. So there's a 22% false negative rate with this culture, and there's an 18% misdiagnosis for the multi-pathogen infections. So our hypothesis is implementing the use of this PCR testing to diagnose UTIs will decrease the time to treatment. 3 to 5 days is too long, which will lead to faster symptom resolution compared to subjects who receive treatment based on standard urine culture. So the primary endpoint is to define whether providing PCR results from urine specimens in patients suspected of having a UTI shortens the time to improved outcomes. And this will be measured as the time in days from enrollment to resolved symptoms. And then the secondary outcome will to compare the pathogen identification by the PCR to the urine culture for technical comparison. So this will be good to really have this data. We'll go ahead and go to the next slide. So our study is an unblinded, prospective, randomized controlled trial, and we want to enroll 480 subjects, male or female, age 50s and over. The study population will be subjects from UofL Health facilities, specifically where we see patients at the Traeger Institute Optimal Aging Clinic, which is a lot of older adults. We see people there 50 and over, and then at Trayton Oak Towers, which is the nursing home on 3rd and Oak downtown, where that's our teaching nursing home where the family medicine residents go for their continuity nursing home experience. And then the intervention arm is 240 patients that receive the PCR diagnosis estimated day 2. The control arm is 240 patients with urine culture diagnosis estimated day 3 and 5. Okay, we'll go to the next slide. And so definitely this study is in partnership with HealthTrack RX. They have a collection device packet and the courier sample pickup and drop off. So it's really the speed of getting all this done, which is key. So you can see the picture there, that one universal collection device, and that's for one universal collection device is it's very, very simple. It's just one vial, regardless of the pathogen. And so next steps, we have to complete the IRB review, and we're not through that process yet, and we expect to enroll patients in September. And go to the next slide. Yeah, I thought that was it. Okay, perfect. So that kind of gives you an overview of just, but it's very, it's amazing that we have this right in our backyard, and so that we can be able to do this and do it efficiently in partnership with UofL Health, UofL School of Medicine, UofL, and HealthTrack RX. Thank you so much.
Thanks, Christian. I'm gonna open this up to all questions, whether it's about the project, about the EVPRI office with industry partnerships. If there's any questions that anyone has, please just jump right in there or put it in the chat.
I think there's a lot of stuff in the chat I haven't been able to keep up.
Yeah.
Excuse me, I added a bunch of things for our announcements in the chat because we typically almost always go over with the presenters and I don't have time. Plus you'll have this afterwards, it'll be in the chat. Again, Christian, that was very informative, and Steve, thank you for joining us. Amy, did you have any other comments that you wanted to share? And does anyone have any questions?
The only other comment is what we wanted to illustrate today is a successful working partnership with an industry partner. And I would say that for all the folks out there, and there's quite a few people online, please reach out to our office if you have ideas about industry partnerships. Everyone in this office is trying to get out more and visit the researchers and clinicians to understand what you're working on. What are the innovations that you're doing? What are you thinking about? Because I think this is a real big opportunity for UofL. This, like I said, this group that Lori and I are the industry partnership team for research collaborations. That's different than licensing patents. That's another group. But we're relatively young at U of L here. We've been around for a couple of years. And so we're trying to get our name out there. Feel free to reach out to us so we can learn more about what you're working on. And then as we are working with industry partners, then we'll have ideas about where there could be collaborations. Dean Bumpus, you have your hand up. Oh, I'm sorry,
I'm
Steve.
sorry.
Did you want to say something?
I'll wait for Dean Bumpus to share.
No, I just quickly thank you very much, Amy. And I just wanted to thank both Dr. Goldberg and Dr. Furman. This is just an outstanding presentation. You know, it fits under the overall aegis, I think, of precision medicine and precision medicine research. And I think this is something we can feel good about. I think Steve's strong and his company's strong work with UPS to develop the HealthPort area near the airport allows us to be really uniquely positioned as a community to make a difference in this area. And I think, you know, one of the things that has been a vexing problem in healthcare for years and years is our inability to bend the cost curve in medicine. And a lot of it is because of excesses, where we overtreat or we inappropriately treat. So being able to treat more appropriately, and I really am so grateful for Dr. Furman in geriatric medicine and our colleagues in infectious disease to really be thinking about this nursing home population, one of the fastest growing elements of medicine and of, you know, certainly of society is our aging society. So, you know, this is an opportunity. I'm just thrilled to see 74 people at this meeting, Amy and Dr. Klein. And I think that I hope some creative juices are flowing and we think a little more broadly. I will tell you, for folks who are interested, Steve is so great. Steve and his company are so gracious. Their facilities are amazing. And we're just so appreciative to have this partnership.
Thank you for that. And thank you for,
I'll add
the aging population.
Yeah, I'll add a couple things. I'm part of ULP. I practice Friday afternoons in the family medicine office at 215 Central Avenue. And then I do urgent care shifts every few months to fill in. So I'm all about U of L. And, you know, it was very compelling initial conversations with leadership and the meeting immense talent right here. And frankly, I'd like to be available to anybody on this call as you're exploring a research idea to see if I can be helpful to network. We've got 40,000 new square feet at this beautiful facility. By the way, we're only 1/4 of this 100,000 square foot building, of which a second one is already committed and filled. So I think rapid resulting of personalized medicine is going to be an expanding industry in our community. And I'd love for U of L to be number one thought for any research opportunity for any of those present or future enterprises.
That's great. That's exciting news.
Yeah, that sounds great.
Thank you, everyone. If no one else has any questions, I'm going to hand it back over to John Klein. John has joined us now. John, do you have any leadership updates that you would like to share?
Well, first of all, I want to thank everyone who presented today. This is one of the most exciting things going on in Louisville and U of L, as far as I'm concerned. The expansion of what's known as UPS Health and UPS Labs has tremendous potential for collaborations with the university, and I think there's going to be more news about that in the near future. So in sort of general research updates, I wanted to let everyone know that, you know, we continue to monitor for discontinuation of grants. It has been a while since we had a discontinuation, and in fact, we had one restored as a result of a lawsuit from the Public Health Association versus the NIH. So that R01 has been restored. It's been quiet, maybe as they say in the movies, too quiet, that we have not seen additional grant terminations. But it's also my moment to remind all of you that the investigators will hear first, and sometimes it's several days before we are notified in the research office. So if you do have any communication, either restoring a grant, intimating that will be discontinued, or a discontinuation notice or stop work notice, please let us know in sponsored programs. Last but not least is the process of trying to figure out where indirect cost dollars are, where they're going to be and how they're going to be calculated. It continues in Washington. There's a joint advisory group from several national organizations that has presented two models. We were fortunate enough to have two people at the meeting in Washington when they premiered the models. They're pretty much finalized now. We have a group working under Dr. In Kim and Rand Haley and others to pressure test, that is to say, to use our actual numbers and see in these models where we would end up and how we would then be able to use indirect cost dollars. That will probably be written into the budget bill in the fall, the new indirect cost model. But that's assuming there is a budget bill. If we don't get a budget, then we'll have a continuing resolution and we will continue with our negotiated 57% rate. So it, kind of quiet summer doldrums. And thankfully after February, March, April, May, it's good to have a little quiet in research administration. Last but not least, we sponsored programs, as did the whole university, went live with Workday. It is creating a very large amount of additional work behind the curtain at sponsored programs. So I ask everyone to have patience and some grace with sponsored programs. They are answering questions as quickly as they can. And it may look from the viewpoint of people using it that everything is smooth as silk with Workday, but a lot of extra work is going on behind the scenes. So that's really all I have today. And we'll be having a town hall again in August, of course, and we are in early discussions about an in-person town hall in September.
Thanks, John. Any questions for John? All right. So of course, the day that I put all of the announcements in very detail into the chat, I have time to talk about them. The first one I wanted to highlight is a proposal opportunity from the Kentucky Cabinet for Health and Family Services with the State University Partnership Program. The initiative basically is in place to connect university researchers with the cabinet to expand research capacity and support policy making. I can't even talk. And there's this year 20 different focal areas of interest. It's very, broad in the areas. So I encourage everyone to take a look at the opportunity I've included. There is, the proposal is pretty short and straightforward. It's primarily a SurveyMonkey questionnaire to some point. Proposals are due September 1. The second one has to do with the NIH Centers for Biomedical Research Excellence program. This typically runs in January, and the eligibility for this depends on the level of phases that we currently already have awarded here to UofL. We currently have a proposal that is being under review, and there is an opportunity for people on campus that are established researchers by medical researchers to submit an internal proposal. And the idea that we would like to do is not only start seeking ideas for a potential proposal in January, but to more importantly, create a pipeline of proposals that may not quite be ready for a submission in 2026, but might be able to do one in 27 or 28. So I've included the criteria. We do have the application process for the letter of interest in InfoReady, like we do other competitions. And this is not a competition. This is just, we want to see ideas. We want people to think about what makes these types of proposals competitive. So what we have asked for as far as things to include in the letter is those things that we know are important to the success of the program. The third item is I want to remind anyone that typically applies to the NSF Major Instrumentation Program. This program this year in November is not going to run, and it's because last year they received so many proposals that ended up being reviewed as meritorious that they have decided to potentially, if funding becomes available, to fund proposals that were submitted during that cycle that may have received a good score last year but wasn't awarded. Maybe they were on the pay line. So there will be November 2026, they will run another competition, but I just wanted you to be aware that this year they're not soliciting proposals. The other thing that I would like to highlight is we've been working with a group of administrators across campus, particularly in partnership with the Speed School of Engineering. Jackie Smith has led a team of administrators to develop a mechanism for us to collect proposals that faculty have submitted that ultimately were successful and awarded. And the idea is to make those available to others as examples. And so we're going to unveil the system in two phases. The first phase is for asking for people to submit their proposals to us so that we can put it in our repository. And then after we get sufficient number of proposals, we will then open up the second phase, which is giving everyone on campus the access so that they can see the proposals. The great thing that we have designed by using SharePoint is you have an ability to sign off and approve what has been posted. You can also redact anything in a proposal that you do not want to share. So if you only want to share the narrative and nothing else, that's fine. If you're okay with sharing the entire thing, that's fine as well. We did set it up to where you, if you're too busy, but are willing to share your successful proposals, then they can have a proxy, an administrator will upload them for you, and then you will be able to approve them that, you know, somehow the proxy didn't inadvertently submit something they shouldn't. So that's been over a year in making, which, because it sounds very simple, but to create the back end of getting the right type of access set up took longer than we had anticipated. We hope to send out an announcement formally about that and the link for where you can submit your proposals in early August. Anyone have any questions about those 4 announcements? That's all I have. Anyone else on the call have anything you would like to share? I'm looking at the chat. It looks like Cecilia has uploaded some information in August. We will be doing another special town hall like we did in the spring, and this will be a Q&A session with John, and we will be submitting a form for people to fill out if they have any questions, and then we will collate those questions, and John will do his best to answer as many as he can in the August town hall. So I hope you look forward to that and send us lots of questions.
One more. I said I was going to do this every town hall. Again, I urge everyone to go to profiles.louisville.edu and create your online profile. It takes about 15 to 25 minutes if you have an ORCID number. And if you publish in a journal these days, you have an ORCID number. But it then will automatically update and pull in any new grants or publications into your profile. It is really straightforward. I think it took me about 15 minutes to do the whole thing. So please do that. It is how we are helping people match up in new collaborations. And going forward, it'll be really an essential tool in deciding how do we dispense research resources based on collaborations that exist. And the tool can show us collaborations. It's kind of a cool aspect of it. You can see your own collaboration interaction map within the university. Once you have your profile set up, it goes ahead and looks very much like a gene interaction or protein interaction map. We use that to make strategic decisions. So if you're not there, then it's harder for us to make it. I also understand that some schools, their data does not lend itself, and that's something that we're working on, lend itself to being imported easily into the system, and we are working on how to solve that.
So John, can you repeat the website URL of where people could go?
Profiles.louisville.edu.
So is this different from Elements?
This is Elements.
Thanks. This is Elements. Okay.
Yes.
Thanks.
And Elements has some real drawbacks, but overall it's a good tool, in particular in the physical and life sciences. But we've seen it used in a wide variety of schools and colleges across the country. The one place where we have some barriers is in the Brandeis Law School, but we're working on that.
All right, I think we can close for this session. I thank everyone for joining us, and I look forward to seeing you guys in August. Have a good day.